Please, can you mute everyone?
Huh.
Thank you for the opportunity for the opportunity. Mr. President, invited the staff of the global profession, wonderful participants, ladies and gentlemen. It is with great honor to be invited to give remarks on behalf of the CEO of Reality Chambers Society. The CEO has been cut up with an equally important assignment, and I'm privileged to give the remarks on his behalf. When we say best Asphyxia,
I think the presenter left that position because the wavelength wasn't good at that position. So going back there is not helping us. Can we go back to where she was sitting before now?
When we talk of birth asphyxia, it is a global concern, claiming the lives of many newborns. About 1/3 of newborn deaths in Ghana is attributable to intrapartum hypoxia and birth asphyxia. Birth asphyxia is a very preventable condition with optimum care of the pregnant woman in labor and even ANC, during ANC. Which means we can reduce or prevent neonatal mortality and morbidity and mortality if we take good care of our ANC and also the labor, during the labor. We can really prevent most of our neonatal morbidity and mortality. On this note, I will welcome you all today to today's program. It is my prayer that today's awareness creation will bring to the fore the need for us as a nation to expedite our efforts to reduce the incidence of birth asphyxia and neonatal mortality as a whole. May the good Lord grant us a successful program and lead us through this successfully. Thank you, and we
Thank you very much, Mrs. Okon Amwa. Thank you very much, Mrs. Okon Amwa, for that wonderful message. We'll take another solidarity message by the representative of the Society of Obstetricians and Gynecology of Ghana. Please, if the representative is ready, can you please give us your solidarity message? Thank you very much. Please, is the rep ready? Please, is the rep for the Society of Obstetricians and Gynecologists of Ghana ready? If not,
Hello.
can we take a solidarity message from the rep of the Ghana Registered Nurses and Midwives Association?
Hello. Hi, this is Dr. Opon.
Please, is the rep of the GRNMA ready with the
Yes.
solidarity message?
Please, if you're having challenges reaching people for the solidarity messages, can we skip and go to the other items on the agenda? Please, can the host bring this to the attention of the MC? If you could skip the solidarity messages and go to the rest of the agenda, then circle back to it when they are on. Yes.
I take it then that we'll do with the solidarity message from the Sinyani Teaching Hospital. Next on the item is the fundraising. I'd like to call upon Dr. Emmanuel Opon, the Vice President of the Pediatric Society of Ghana and the Treasurer of the Pediatric Society of Ghana to take over for the fundraising. Thank you very much.
Which place best? Hello. Yes. Can I be heard, please?
Yes, please.
Hi. Good afternoon, everyone.
Yes, please, you can.
It's exciting to see the number of people on the call and the number of people who are passionate and interested in the society championing this cause to deal with birth asphyxia. Over the years, as a society, we have observed that some facilities are having challenges on the basic equipment and items that is needed to prevent and to manage cases of birth asphyxia properly. So as part of this year's celebrations, we are very excited to let members and all stakeholders here know that part of this year's celebration will involve fundraising, specifically to mobilize resources to buy very essential items that we know can make a difference in the management and prevention of birth asphyxia in some of the facilities. So in the course of the month, the society will be coming to you on various platforms to invite all of us to support us mobilize some funds and also lead us to potential partners to mobilize funds and garner some of these resources that we can use to support some of these facilities to improve the prevention and management of birth asphyxia. So I entreat all of us to enjoy and follow all the activities that have been planned by the Brong-Ahafo region, who are kindly hosting the Asphyxia Awareness Month. And let's all pitch in as we've always done and work together to prevent and deal with all the issues of birth asphyxia that arise. So let's enjoy the rest of the program, and we'll come to you with more details about these fundraising efforts. Thank you, and over.
Thank you. Okay, thank you very much, Dr. Emmanuel Opong. We'll take Sorry about that. It's one of those days. Please, can we go ahead? Thank you very much. So we'd like to take our first presentation. We are moving into the second session. We want to take our first presentation. And that will be delivered by Dr. Charles Edu Techi. Dr. Techi is a senior specialist obstetrician gynecologist, fetal maternal with passion for maternal health. He is a fellow of the Ghana College of Physicians and Surgeons, a member of the West African College of Surgeons, a member of the Society of Gynecologists and Obstetricians of Ghana, and of the Ghana Please, is the sound audible now?
Yes, please, very audible. We can hear you very well. Very clear.
Okay. So thank you very much. Let's take our presentation from Dr. Edu Techi. Over to you, please.
Okay. Good evening, everyone. Good evening.
Good evening.
Okay. I'm very happy today to be here to give obstetrician gynecologist input on the prevention of sex asphyxia. There's a outline, a brief introduction. Hello. Can I be here, please?
Yes, please, we can hear you.
Dr. Techi, please, we can hear you. Can go ahead.
Okay. Let me share my screen again. Okay. Please, can my screen be seen?
Yes,
Hello.
it can.
Yes. Okay. Okay. So perinatal asphyxia can result in profound systemic and neurologic sequelae. It can lead to death, permanent brain damage, or developmental delays. In most technologically advanced countries, it's about 1 to 3 per thousand live births. But in Ghana and in the poor resource settings, it's about 30 per thousand live births. According to the WHO, majority of births are actually occurring in women who have no risk factors at the time they entered labor and delivered, and then their babies too at the point had no risk factors. So we'll delve into the main causes of birth asphyxia in Ghana and sub-Saharan Africa and how to prevent them. So it's usually caused by antepartum events, intrapartum events, and then postpartum events. Or it can be grouped as maternal, fetal, placental, intrapartum, and neonatal. Okay. So there are other acute events that cannot be put as either antenatal or intrapartum or postpartum. Examples are if a patient is either pregnant and gets a ruptured uterus, or if a patient is in labor and gets a ruptured uterus. Other hypoxic events are abortion, placenta, cord prolapse, or amniotic fluid embolus in the mother, which can lead to shock, and then the fetus will not get oxygen. Other causes are fetal blood loss from a vasa previa. So vasa previa is basically fetal vessels that are usually lying close to the cervical os, but they are not covered by the umbilical cord. They are not covered by the Watkins jelly. So slight trauma, these vessels break, and it's fetal blood, and the fetal blood is very, very small. So with very, very little amount of blood loss, the fetus dies. So now we delve into the various causes. Maternal causes. These are women with chronic medical conditions that may affect them or give them underlying risk factors for obstetric complications. Such women are usually women with sickle cell disease, SLE, antiphospholipid syndrome, or some women are even had heart diseases that were first diagnosed in pregnancy, or women with thyroid disease. Other maternal causes have been listed below. Pre-eclampsia has been a major problem for us here in Ghana because it's very, very common. So we'll talk about the other causes. Fetal causes, multiple gestation. Usually, the second twin is the one in trouble. And then fetuses that are born with congenital malformations, prematurity, post-term babies, IUGR, or small for gestational age babies, or babies with breech presentation. And sometimes too, birth asphyxia is caused by trauma. Either you are delivering a breech, you fracture a long bone, or there's a trap after coming head, and then various attempts are made to deliver that head, or sometimes even from vacuum delivery. So delivery and intrapartum causes. This is the main problem here in sub-Saharan Africa. So usually it happens in in knowledge, they usually get a prolonged first stage of labor. That's a labor that's going beyond 12 hours in the active phase, or sometimes even in grand motives, because they have given birth before. We always feel that they can deliver, and then sometimes their babies are big, and then proper assessment is not done to find out the weight of the babies before the women come in labor. And then sometimes there's a prolonged second stage because of poor maternal effort. Usually this happens in the knowledge. And then the obstetrician will try to deliver with a vacuum extraction. And then the prerequisites that are supposed to be followed to make sure that baby and mother are safe are sometimes not followed. So such babies come out very, very bad with severe caput, sometimes subgaleal bleeds. Other causes that can happen in the intrapartum period are called prolapse, shoulder dystocia, where after delivery of the head, the shoulders fail to deliver. And other causes can be maternal shock from any cause in labor. Okay, so placental or cord causes. I've mentioned vasa previa. I've mentioned abruptio. Sometimes we get a major previa, that is a placenta that is wholly covering the internal os. When this happens and the woman starts bleeding, the woman loses so much blood that the fetus also becomes hypoxic. Other post-delivery causes are here. So when we come to our NAXA labor ward, the main causes of birth asphyxia after talking to the midwives were prolonged prom, that is premature rupture of membranes more than 24 hours with subclinical or sometimes overt infection, which is called chorioamnionitis, or sometimes prolonged labor or second twin or cephalopelvic disproportion. These were the top 4 that came out as a causes of asphyxia from our NAXA labor ward in Kumasi. In May, they had the lowest birth asphyxia of 5.2%. That was 7 cases out of 135. And in April, they had 16 cases out of 127. That gave a birth asphyxia rates for that month to be 12.6. Okay. Then our theater, our NAXA theater, the main causes of birth asphyxia were pre-eclampsia with severe features and eclampsia. It must be said that most, about 50 to 60% cases of preterm pre-eclampsia can be prevented if at the antenatal period proper history examination is done, so that some of the women are put on soluble aspirin. A study was done here at CAT by Dr. Yao Ousu Jante, and he found out that about 60% or more of preterm pre-eclampsia can be prevented if women are giving low dose soluble aspirin. Okay, so I went to the MBU at the NAXA block, and then the neonatologists also gave me their side. Usually, they said prolonged labor also was the main cause of the cases that they were getting. And again, failed vacuum came up, and then CPD and a few cases of cord around neck. So prevention of birth asphyxia. How do we prevent it? It's primary, secondary, tertiary. So primary, that is mainly pre-conception care, to pick women that have medical conditions, assess them, manage the various underlying complications that they have, to make sure that before those women even get pregnant, they are in the utmost state of health. Again, the primary can be at the antenatal section, where again obstetricians have to take proper history, review the records that the patients have, and then institute measures to prevent complications. So the secondary is to early diagnose and treat asphyxia. Okay, so we'll zoom in on the pre-conception care. So for example, if a patient comes with sickle cell disease, we all know that they are likely to have a pulmonary hypertension, and those with severe cases are the ones that usually die. Some of them come in HB of 6 or 7, and they are pregnant. So all these poses a risk of hypoxia and then intrauterine growth restriction for the fetus. So proper assessment of such patients should be done, so that if they have to even be counseled out of getting pregnant, that should be done. Some patients come with medical conditions like systemic lupus erythematosus. Such patients, their drugs have to be reviewed so that teratogenic drugs like methotrexate, angiotensin converting enzyme inhibitors, such drugs should be taken out, and then category A, B, or sometimes C drugs like hydroxychloroquine are introduced. So the preconception care is basically to identify patients who have underlying medical conditions, and then manage them, and then identify patients who have certain conditions that we think they shouldn't get pregnant at all. Example are the category 3 and 4, WHO modified heart disease patients with previous peripartum cardiomyopathy, with residual left ventricular failure, patients with severe mitral stenosis. All such patients should be cancelled out of getting pregnant in the first because it has been found that it is the class 3 and 4 patients who have heart disease that usually die during pregnancy. Now we go to antenatal care. Antenatal care, it has to be said that all high-risk pregnancies have to be seen by a doctor or by an MFM specialist. I know there are a few, but in the next few years, I'm sure every region or district will have an MFM doctor, a maternal fetal medicine doctor. So basically, it's the same thing. History, review of records, examine, investigate, counsel, and then institute measures. So for the chronic hypertensives, low dose aspirin can be given 150 milligrams for the HIV patients to make sure that they are on their drugs. Adherence counseling is done so that they are not prone to infections, to also reduce the risk of vertical transmission. The DM patients are also supposed to be managed well pre-conception and then at the antenatal clinic, because we all know that DM with hyperglycemia is not good, because hyperglycemia has been found to be a children. It can lead to CNS defects and heart defects. Okay, so the main problem in sub-Saharan Africa is intrapartum events. So we'll spend most of the time here. According to the WHO, women in labor must be seen by skilled birth attendants, whether it's a midwife or doctor. So the birth attendant may have the skill, but may not be devoted, or as we say, in Kumasi here, may not be conscious. The person must be vigilant, pick up risk factors that the patients came with in labor, pick up risk factors that the patient developed in labor, and then monitor well, because the WHO wants all pregnant women in labor to have regular monitoring for the women themselves, the babies, and then communicate with the women who have come in labor. Because of this, we have to do this or that. All birth attendants have to be trained in neonatal resuscitation. All labor must be charted on a pantograph, so that if there is prolonged labor, you pick it up. If the fetus is not doing well, you pick it up. And then I'll put something here: timely interventions. Most women that come to labor have no risk factors, so any woman can develop any complication at any time in labor. That's why I put here that seniors must be at work and be working. Not that seniors go and then leave the younger ones there, or seniors go and then find themselves somewhere in bed. They have to teach the younger ones. They have to work. They have to be at the labor world to teach them how to pick up risk factors. And then another problem that we have in the intrapartum courses is usually the second stage of labor, where the fetal heart rate must be monitored every five minutes. Now the deliveries at CAT have gone down, so monitoring should be better, but that is not the case. And then sometimes the prerequisites to even start a vacuum delivery is not met, but some doctors still go ahead and put a vacuum cap on the fetal head. The fetus may be big, the station may be -1, -2, but they will still try it because they are tired, or they don't want to go and do the cesarean section. So if seniors are there and they are supervising them, I think most of the issues in labor can be averted. Okay, so according to the WHO, when we improve quality of care around the time of birth, we are going to reduce newborn deaths and maternal deaths. Every woman wants a positive childbirth experience to get a healthy baby and then go home. They should be seen by staff who are devoted and are also properly trained. This picture that we are seeing is a mother who has just delivered and is happy. This should be the ideal for every woman who comes in labor. So this is what we want. Husband, mother, baby, all happy. Unfortunately, in sub-Saharan Africa and then Ghana, our neonatal mortality rates is about 22.8 per 1,000 live births. That is very, very poor compared to what the UN and the WHO wants us to get to. That should be 12 or lower per 1,000 live births. Okay, so thank you, everybody. I brought my presentation to an end. Hello.
Thank you very much. That was a very insightful presentation. Okay, so I've just been alerted that our guest of honor, Dr. Marion Okun, is ready now. So please, we would like to stop sharing. Okay, so would like to take our guest of honor's speech. Our guest of honor is a senior specialist, like I introduced her early on, public health physician, an accomplished woman of many firsts, among which are the first district director of health services of the newly created Mpoho district, the first Ghanaian secretary general and co-chair of the Medical Women International Association, the first regional director of health services of the newly created Western North region. She brings to this discussion wealth of experience as a health systems expert and the national lead in policy translation, implementation, monitoring, evaluation, coordination with regards to maternal, newborn, child, and adolescent health and nutrition in Ghana. Please, let's be ears for our guest of honor, the Director of the Family Health Division of the Ghana Health Services, Dr. Marion Okun Owusu. Over to you, Dr. Okun. Thank you. Dr. Techi, can you please stop sharing your screen for us? Okay, thank you. Please, is Dr. Okun ready now? Please, Dr. Okun, are you on the call, please?
She is not, please.
Okay, thank you very much. On behalf of the hosts, the BA Division of the Pediatric Society of Ghana, I would like to apologize for the technical challenges. As much as possible, we try to work to resolve all the challenges we are facing. Please accept our apologies. Thank you. So we'll be taking our final presentation on the theme Overview and Management of Birth Asphyxia. That presentation will be taken from another seasoned specialist. So that presentation will be taken from someone who is a lecturer at the Department of Child Health of the School of Medical Sciences, KNUST Kumasi. She is a specialist pediatrician as well. In her bid to see all babies breathe well, she has been a facilitator for the Helping Babies Breathe program from 2014 up till date. She is also a member of the Ghana Medical Association, the Pediatric Society of Ghana, the West African College of Physicians, the Ghana College of Physicians and Surgeons. Our presenter, Dr. Ekia Efriye, please take over. Thank you very much.
Thank you very much for the introduction. Mr. Chairman, distinguished ladies and gentlemen, all protocols observed. I deem this a great honor to be called upon to share a little knowledge about birth asphyxia, and I'm very grateful for the opportunity. And I want to thank Dr. Dutechi so much. He has done almost all my work for me. Thank you so much. And I hope that we are able to implement all that he said. Because if you're able to do that, then maybe next year when we meet, it will only be celebrations. And that will be it. So thank you for this opportunity. Now, pause a little bit. We have had a lot of sessions, a lot of talks. Let's pause a little bit. Let's do a little bit of reflection. Assuming after a long week's work, after a long day, like today is Friday, after a long day, you want to cool off a little bit. So you stroll to a restaurant close by where they have a very serene environment. They have a pool where you can sit and can take a sip, reflect on your life and cool off. So you decided to take a stroll to the restaurant. You've taken your drink, you've sat for a while and decide to take a stroll around the pool. And as you are in the process, somebody from somewhere, from nowhere, just pushes you into the pool. And here you are, struggling to breathe, struggling to get out of the water because you have been pushed. And like me, you don't know how to swim. So what do you do? Now let's get to my presentation, birth asphyxia, overview and management. So we'll look at the end of this session, we'll look at the definitions, some few definitions when we talk about birth asphyxia, epidemiology, pathophysiology, effect, management, and prognosis. Now, when we mention birth asphyxia, there are some few terms that tend to hover around birth asphyxia, one of which is hypoxia or anoxia. What is hypoxia? Hypoxia refers to a partial lack of oxygen at the tissue level, and anoxia refers to complete lack of oxygen at the tissue level. Now, we always talk about asphyxia. Oh, this baby has asphyxia. That one has asphyxia. What do we mean by asphyxia? It's a state in which placenta or pulmonary gas exchange is compromised or it ceases altogether. And now we also usually speak the term as ischemia. What is ischemia? Ischemia occurs when there's reduction or cessation of blood flow to an organ which compromises both oxygen and substrate delivery to the organ or tissue. Now, what is birth asphyxia in itself? In very simple terms, birth asphyxia refers to failure of the baby to establish breathing at birth. Now, when we consider this definition, sometimes it causes us to narrowly look at what happens at birth only. But from Dr. Dutechi's presentation, we realize that events that occur prior to the delivery, during the delivery, and soon after delivery can all impact the baby and cause asphyxia. That's why, although perinatal and birth asphyxia, they are synonymous, they are sister terms, they can be used interchangeably, and they'll be used interchangeably in this presentation. We prefer the perinatal asphyxia because it gives you a broader outlook of what we are talking about. So what is perinatal asphyxia? Is when you have lack of oxygen, lack of blood flow or gas exchange to the fetus in the period immediately before, during, or after the birthing process. So when we look at perinatal asphyxia, it now tells us that There can be issues before the delivery, there can be issues during the delivery, and there can be issues soon after the delivery. And all this can culminate in perinatal asphyxia. And so if we are talking about it and we want to prevent it, then we need to look at it from all these points of view. Now, let's look a little bit about epidemiology. I will not bring local statistics because Dr. Dutechi has done justice to that. But from the global point of view, we know that birth asphyxia is a very important cause of neonatal mortality. It is claiming the lives of babies, especially in the sub-Saharan African region where Ghana is situated. It is claiming the lives of our future president, astrologists, engineers, architects. That is why we are all gathered here. We need to do so much to prevent these deaths, to save these babies alive so that they can grow and have a future. Now, let's delve a little bit into pathophysiology. When birth asphyxia happens, what occurs? When it happens, usually what happens is that the body will start defending itself. Remember finding yourself in the pool. You will not just say that, oh, now I'm in the pool, oh, I am here. Oh, no, your body will start defending itself. You will start gasping for breath. You will start throwing your hands around so that somebody will see you to rescue you out of the pool. The baby does the same thing. So the baby will now put in some mechanisms. And this mechanism is to ensure that the little blood that he has is shunted to very vital organs to protect the baby and prevent it from dying. What are these vital organs? The brain, the heart, and the adrenal gland. And that's what we call the diving reflex. That's what you call the diving reflex. So there's shunting of blood to the brain, the adrenals, and the heart. But this has implications. It implies that blood is shunted away from other organs like the lungs, like the kidneys, like the gastrointestinal system. Now, from this outlook, then it means that when we are talking about birth asphyxia, it's not just the brain that is affected. Other organs are also affected. Now, let's delve a little bit into the tissue, what happens at the cellular and the tissue levels. So, first and foremost, with asphyxia, we know that there is compromise in gaseous exchange at either the placenta level or the pulmonary level. And when there is this compromise, it means that we are getting insufficient oxygen into the body. And that results in hypoxia. Now, this hypoxia that is occurring at the cellular level is leading to a decrease in the production of energy, and that results in cellular damage. Now, if the hypoxia occurs over a very short period of time, then the cellular damage that occurs is reversible. However, if the hypoxia is sustained over a prolonged period of time, then it will result in irreversible cellular damages. And the implication is that complications will now start setting in. So from the little that we have learned from the pathophysiology, it implies that birth asphyxia or perinatal asphyxia can lead to multi-organ dysfunction. It can lead to multi-organ dysfunction because every organ is affected. In the early stages, there can be shunting of blood to preserve the brain, the heart, and the adrenals. But if hypoxia is sustained, it means that even the brain, the heart, the adrenals, they will all be affected. Hypoxic events will occur there will be cellular damage, and then it will lead to organ dysfunction. Moreover, even before the shunting, we are already depriving the gastrointestinal system, genitourinary system, the pulmonary respiratory system, we are already depriving them of oxygen. So already there is cellular damage occurring in these tissues. So it means that birth asphyxia has got effect on every system of the body. It has got adverse effect on every system of the body. Now, let's take some of the systems and what birth asphyxia does to them. For the cardiovascular system, it can lead to reduced myocardial contractility. And then clinically, when you see this baby and you are trying to check the vital signs, you realize that the pulses, the volume is very low, and even the rates can be low. The baby can have bradycardia. It's all because of the effect of birth asphyxia on the heart. Now, in the respiratory system, birth asphyxia can lead to pulmonary hypertension. What do we see on the baby? Baby will come in with respiratory distress, and then sometimes low saturations, all because of the pulmonary hypertension that the baby is having as a result of the birth asphyxia. In the urinary system, it can affect the kidneys. Once we know that blood has been shunted away from the kidneys, it can lead to acute tubular necrosis. And what do we see clinically? We see that the baby has a reduced urine output, and it can have electrolyte imbalances as well. Now, with the gastrointestinal system, what happens? Blood has been shunted away from this system, and so the gut walls are not well perfused. So when you feed the baby cannot digest because you need the blood vessels to aid in absorption. So there's delayed gastric emptying. Again, if the hypoxia is sustained for a prolonged period of time, then you will have ischemic changes to the bowel walls. And this can lead to necrotic changes as well. So this baby who is born at term will have features of necrotizing enterocolitis because of the effect of the asphyxia on the gut. The liver is not spared, and so usually the liver function is deranged. With the hematological system, these babies can present with thrombocytopenia, or sometimes they can have disseminated intravascular coagulopathy. So you can see this baby who is there asphyxiated. You try to do a heel prick for random blood sugar. After your heel prick, the blood is not clotting, the bleeding is ongoing. You do any peripheral cannulation or any just for sampling, and the bleeding is not stopping because of coagulopathy. Sometimes some of these coagulopathy can go to the extent that sometimes these babies may vomit coffee ground vomitus because they have an upper GI bleed, all because of coagulopathy from the birth asphyxia. So we realize that birth asphyxia is a multi-system disease. It's a multi-system disease. Now, when we talk about birth asphyxia, most people will even equate it to hypoxic ischemic encephalopathy. They are not so wrong, because the effect of birth asphyxia on the brain is usually irreversible. It causes irreversible brain damage. So I've talked about so many of these other systems and the effect of the birth asphyxia on them. But God being so good, when we are able to manage the conditions well and support the babies, so many of these systems gradually recover. They gradually recover. So most of these asphyxiated babies, they do not grow with these effects on the other systems of the body. However, when it comes to the brain, if hypoxia is sustained and the brain is deprived of oxygen, you see the brain, when it is in the third trimester and in the first year of life, the brain is growing very rapidly and requires a lot of oxygen supply for this growth to take place, to undergo all its metabolic activities. So the brain is very oxygen sensitive. The fetal brain, the early neonatal brain is very, very oxygen sensitive. What is the implication? The implication is that when it's deprived of oxygen, the damage can be very severe and the damage is irreversible. So hypoxic ischemic encephalopathy, when it ensues in the baby, the damage to the brain becomes irreversible. So even if the baby is able to survive the whole episode of birth asphyxia, it will have long-term sequelae for this child. Something you cannot reverse. And that is why we are hammering on birth asphyxia. As much as possible, we should do all we can to prevent this condition that is taking the lives of our babies. And even if the baby survives, it is going to have a very, very dire consequence on these babies. So they can present with seizures, lethargy, poor feeding, irritability, all showing that the CNS has been adversely affected by birth asphyxia. Now, what do we do? What do we do? This is where our theme comes in. Breathing life in every baby. Breathing life into every baby. We need to have prompt resuscitation for every baby who fails to breathe at birth. We should be ready with our resuscitation corner. Every facility that delivers babies should be ready with a resuscitation corner, should be ready with resuscitation sets. And this resuscitation set should not be gloriously packed into a room which is inaccessible, so that when the baby comes, we are now going to look for the in charge, get the key, try to run about whatever kilometers to get to the room, unlock it before we get the set out, before we can attend to this baby. Please, birth asphyxia is a timely event. It's a timely condition. Even if you waste 1 second, it is going to have dying consequence on the baby. So it's important that we have our resuscitation corner, our resuscitation set, which comes in handy, always present, and the personnel, a trained personnel at each delivery, at every delivery. Please don't tell us that, oh, as for this woman, this is the 4th delivery, and this woman, oh, the way she is blessed. Anytime she comes to this facility, it doesn't even take 5 minutes, the baby is out. If you listen well to Dr. Edutechi's presentation, he said that, yes, there can be high-risk women, but even the low-risk women are the ones that sometimes poses a lot of challenge, where you think that there shouldn't be any challenge at all. That is where birth asphyxia will raise its ugly head. So please, at every delivery, let's not take any delivery for granted. Every delivery, we should be ready with our resuscitation set, with our resuscitation corner, with a skilled personnel. Please, all of us on the call, I believe we have undertaken helping babies breathe, undertaking some other, but please, anytime we get the opportunity, always let's refresh ourselves. Nobody has overlearned resuscitation in a newborn. I haven't met some before, whether it's a white person or a black person. We all haven't overlearned it. Let's always avail ourselves for refresher courses so that we are always on top of our game when it comes to resuscitating babies. This our resuscitating kit, just an ambu bag with a penguin sucker. This very simple equipment is very life-saving. It can change the story of a family in a matter of seconds to minutes. So it's very important that we all have it. I believe PSG is trying to ensure that every facility has it. And we are even raising funds. Please, our sponsors, we will put in a word, if only you can, because this simple set can make a huge difference in the life of a baby and the family and the nation as a whole. Because if we save one child, you never know, it will be the solution to our mining, our spoiling of water bodies. to the things that are happening in our country. You never know. So please, this simple set should be available in every facility where labor and delivery occurs. So please, as much as we can, all our stakeholders, let's ensure that this is made possible. Now, with our resuscitation, some simple steps for most of our babies, even the simple drying, ensuring that they are not cold, removing the wet clothing, ensuring that their mouth and their nostrils are suctioned if there are any secretions. These simple steps, in fact, are able to stimulate most of our babies to be able to breathe, even before we apply our ambu bag. So it's important, as I said, to always refresh ourselves and go through the steps. We shouldn't leave any step unattended to. And then if this baby is still unable to respond to our stimulation, then we have to apply our ambu bag. It has to be done in the golden minute, please. In the golden minute. Every minute counts. We have learned that the longer the hypoxic event, the more the injury, the more the damage. So as much as possible, we need to ensure that we are delivering breath to this baby in the first minute, in the very first minute. That's why we have to be battle ready all the time whenever a baby is being born. Now, after we have stabilized the baby, then we can go on to do some investigations. Now, these investigations, first and foremost, are not exhaustive, but in your facility, if you cannot do all this, you don't say that, oh, now let me fold my hand. Let me get a place to refer the baby to, because if I'm not able to do this, I cannot take care of the baby. No. Even if you can do just a basic full blood count, that's fine. You can do that and go ahead and manage your case. Because birth asphyxia, the diagnosis is basically clinical. So if you have the facility, yes, and the laboratory support, yes, you can go through these investigations. But if you don't have them, you can still manage birth asphyxia in your facility. Most important thing is to monitor. Monitoring is very important. Now we have been able to resuscitate the baby. We have been able to bring the baby to the neonatal unit. We need to monitor this baby. Close monitoring of the vital signs, the heart rate, the respiratory rate, the temperature, the oxygen saturation, blood pressure. Blood pressure monitoring is mostly difficult in a newborn because most of us don't have the neonatal cuffs. If you don't have, as I said, it doesn't mean you cannot. You monitor the others. The heart rate, how is it going? The respiratory rate, the temperature, the saturation. How is it? How can I optimize it? Those are very, very important things that we can do to support the child. And the fluid input and output. We have said that the kidneys are affected. So sometimes they are not able to produce the urine that they are supposed to. Meanwhile, we are inputting so much. We have to make sure that there is a balance. So there should be fluid input and output chart so that we are sure that whilst the baby is getting the fluid, the baby is also excreting the right amount of fluid. Daily weighing is also important because sometimes when the baby is not able to produce enough urine, the baby starts swelling up and it is going to lead to an increase in weight. And you have to also monitor for seizures. Very important because seizures, being a result of hypoxic ischemic encephalopathy, if it is prolonged and persistent, it also leads to further brain damage. So we always have to look out. And then we know that in a newborn, seizures can be very subtle. That's why we have to really look out for them. We have to intentionally look out for seizures so that we are able to manage the babies as such. So in our management, anti-seizure medications are necessary. Sometimes if our heart, we are having bradycardia, the child is not perfusing well. So apart from the bradycardia, you realize that the extremities are all palish, all cold. Maybe you've even done giving a bolus of fluid or so, still the perfusion to the extremities are not, it's all because the heart is not able to pump the blood as it should. So sometimes they require inotropic support. Then IV fluid maintenance, because their guts are also injured. You cannot start pumping in so much feed. So yes, we feed them, but we have to start gradually prime the gut, before you push in large volumes. Because if you do that at the go, then necrotizing enterocolitis will set in, the baby will deteriorate on your feeding schedule. So usually we give them fluid, IV fluids, whilst we gradually prime the stomach, and then the baby is now able to feed. And then we sometimes give antibiotics, because sometimes with a birthing process, let's say prolonged labor, the baby has had multiple vaginal examinations and all that, making them prone to infections. So sometimes we cover them with antibiotics so that these babies, at least on top of the asphyxia, they don't get sepsis. And then with therapeutic cooling, which is a newer way of management, and we talk just a little bit about that. We know that in most facilities in Ghana, we haven't been able to do therapeutic cooling. It's because there are challenges with laboratory support, challenges with personnel, because it requires a lot of challenges with resources or equipment. But we are hoping that one day we will get there. That is, if it helps our children. Because sometimes things that are helping somewhere else may not be helping in our environment. But we hope that as time goes on, we may get to that point. But as I said, birth asphyxia, the best is to prevent it. The best is to prevent it. And when it occurs, the management is mainly supportive. That's why close monitoring is very, very crucial. And if you're able to do therapeutic cooling, if we get there, then we'll be able to do it for them, because studies have shown that it reduces mortality. So it can further reduce mortality. But in actual fact, we wish that we don't get to a stage where we need to do therapeutic cooling. We wish that we'll be able to save our babies from even getting severe birth asphyxia to warrant therapeutic cooling. Now, the prognosis. There are certain factors that affect the prognosis. If the baby is unable to establish spontaneous breathing at between 20 to 30 minutes after birth, then the chances of survival becomes slimmer and slimmer and slimmer. Now, seizures, persistent seizures, can also have a negative impact on the prognosis of the child. Some of them will survive anyway, but when they survive, they can survive with sequelae. Neurological signs like hypotonia or rigidity at 7 to 10 days of life also connotes a bad prognosis. Feeding difficulties. So some of these babies may have feeding difficulties. They cannot swallow. They are always drooling saliva because of pseudobulbar palsy that can occur as part of the brain damage. So with these babies, the prognosis is usually bad because of the risk of aspiration. So on top of the asphyxia, they also have an increased risk of aspiration, which really adversely affects the health of the child. And then as the child grows, if you are monitoring the child, if there's poor postnatal head growth, then it also connotes a bad prognosis in terms of the neurological outcome. So what are some of the complications? There can be cognitive impairment. If you look at the complications, you realize that most of them are CNS complications. As I said, when there's brain damage, it's usually irreversible. So there can be cognitive impairment, there can be cerebral palsy, epilepsy can also occur, there can be blindness, there can be hearing loss. We all don't want to have to see our children suffer so much, and that is why we are here this evening, talking about birth asphyxia. As much as possible, let us ensure that we breathe life into every baby, so that at the end of the day, the babies will happily sleep and they'll be very grateful unto us for our efforts to prevent birth asphyxia in these our lovely little angels. Thank you very much for your attention this evening.
Thank you very, very much, Dr. Epia Efriye Okran. Indeed, no single individual have overlearned the skill of resuscitation. And I am sure you all agree with me that if Passion were a human being, she would have been called Epia Efriye Okran. I'm sure you all agree with me on that. Thank you very much, Dr. Okran. Very insightful, very passionate, and very informative presentation. Thank you. If you can please stop sharing your screen now, we'll be very grateful. Now we'll be taking our questions and answers. It's been a lot of information, it's been a lot of education from both Dr. Edu and Dr. Efriye. So we'll be calling for questions at this point. If we need any clarifications for all participants online and in-house. Thank you very much. We are waiting for your questions, please. Okay, so we have one question, and I'm sure this is going to Dr. Priye. The participant wants to know how different birth asphyxia is from hypoxic ischemic encephalopathy. Dr. Priye, please, are you online? Are you on the call?
Yes, please, I'm here. I'm here.
Okay, so that question, I'm sure is for you.
All right. Thank you very much for the question. So the question is, how different is birth asphyxia from hypoxic ischemic encephalopathy? In fact, they are not different. What is happening here is that hypoxic ischemic encephalopathy is the result of birth asphyxia. So birth asphyxia will lead to hypoxic ischemic encephalopathy. They are occurring together. Whenever there isn't enough blood supply to the baby's brain, then it will lead to hypoxic ischemic encephalopathy. And then we will see all the sequelae. In the very, very short term, we see the seizures, the lethargy, the poor feeding, and the like. And then in the long term, that's when we see the cognitive impairment, the epilepsies, the cerebral palsies. Thank you very much. I hope I've answered you.
I hope so too. Okay, so we take our next question. The participant wants to know, how long should I bag an asphyxiated baby? How long should I bag an asphyxiated baby?
I guess this question also goes to me. And it is a very good question. It has always been a matter of controversy in several circles. So when it comes to bagging an asphyxiated baby, first and foremost, we need to know what is happening. Is the baby having any spontaneous breathing? I guess no, because we are bagging. And then the second question is that, is the child having any heart rate, any activity on the heart? any activity on the heart. If the child has got a heart rate, and most especially if the heart rate is above 100, then we cannot stop bagging. Now, if there is no heart rate, and then there is no spontaneous breathing, and we have bagged this baby for 20 minutes, then we can stop bagging and counsel parents. If there is no heart activity, no spontaneous breathing for 20 minutes, and the baby is not doing anything, then we can stop bagging. But if there is heart activity, then we have to continue bagging for a prolonged period of time. In fact, I cannot give you a time frame. It is a dicey one. It is a dicey one. And I know, and I believe that so many of us who are working in neonatal unit, we are sometimes faced with this challenge where this child, this baby is there, the heart is present. However, the baby is not making any spontaneous breathing. At that point, after you have bagged for more than 30 minutes up to about 1 hour, you have to now start talking to the parents. Talk to them, counsel them on the long-term complications. And then if you are on the same page, you can now stop the bagging. So that one will require a team approach. The head of your team, together with the parents, there should be a sit down so that at the end of it, you are all on the same page on that baby. But if there isn't any heart rate, no spontaneous breathing, after 20 minutes, you can stop the bagging. Thank you very much.
Thank you to Dr. Asphyxia. I'm sure the next question is for you as well. The participant wants to know what is used for the therapeutic cooling. What is used for the therapeutic cooling?
Thank you very much for this question as well. So for the therapeutic cooling, that's why I was saying that we are lagging behind even with the equipment, because we have special equipment for therapeutic cooling, which is not readily available here in the country. I don't know whether at least in my facility, sorry, I cannot speak for the whole country, but in my facility, we don't have it. We can improvise. I mean, I know that people have tried to improvise, but it's always difficult. It's always difficult when we are improvising because you need the temperature to be steady between 33 and 34. And it should be a whole, either you are doing whole body cooling or just the head. So it's quite important that we get the right equipment. That's why I was saying that I personally, from my point of view, for my facility, I think we are not there yet. But then it may not be so in other facilities. And we are open to other facilities, their experiences. But in our facility, we don't, because we don't have the equipment for it. Thank you.
Please continue for us. Another wants to know, if a baby has oliguria, how do you determine fluids to be given within 24 hours? Do you still do maintenance?
So if a baby has oliguria, now, first and foremost, you want to ensure that you optimize the fluid for the baby. So give the baby full maintenance for about 24 hours whilst you monitor the oliguria. Most of them, thankfully, are able to resolve spontaneously, even with just your full maintenance, making sure the baby is not having any fluid deficit. But if this baby with oliguria is also becoming puffy, that's where you have to do fluid restriction, whereby you only give the urine output plus insensible water loss. That's where you restrict the fluid. But if the baby is oliguric and the baby is not edematous, then that one you can go ahead and give your full maintenance and then continue to monitor, because most of them are able to right themselves. That is, they are able to correct the oliguric an episode by themselves. Because as I said, the birth asphyxia, although it affects every organ, most of these organs, they are able to heal. The damages are able to heal on its own.
Okay, so please, is it advisable to keep babies with moderate to severe birth asphyxia under radiant warmers? Please, did you get that?
Yes, please. Thank you very much. That's also a huge controversy that has always been coming up. What I would say is that when we are not doing therapeutic cooling, we want them to be in the optimal temperature, which is between 36.5 to 37.5 degrees. That is the normal neutral temperature we want for every baby. If you are not doing therapeutic cooling, then that is what we want to do. And that's what we do in most of our facilities because we don't do therapeutic cooling. So you only keep under radiant warmer if the baby is hypothermic and you maybe want to warm the baby up. Maybe the baby's temperature is 35 and you want the baby to come up. If the baby is in the normal, within a normal temperature range, then you don't need a radiant warmer. But if the baby is hypothermic, then that one you may require a radiant warmer to make sure that the temperature comes into the neutral temperature that we want for every baby. That's between 36.5 37.5 degrees Celsius. Thank you.
Hello. That was for, I'm sure was for Dr. Edu. The person wanted to know when the tab aspirin 150 milligram is given to the pregnant women. Another participant also wanted to know where they can get some of the resuscitation kits, saying some of the facilities don't have.
And please, I believe for the resuscitation kit, if you don't have it, if you will let us know as we are organizing this, if you let the organizers know, I think PSG has taken it upon itself to ensure that every facility has. So if you don't have, please bring it to the attention of the organizers so that we can forward it to PSG. PSG will now ensure that every facility has it. Thank you very much.
Thank you. David Afrifa also wants to know, how about delivery via CS? Should antibiotics be given to an asphyxiated baby? If yes, what's the principle behind, since such babies were not exposed to multiple vaginal examinations and vaginal birth? Thank you.
Yes, thank you very much. If a baby is delivered via cesarean section and it is not from, let's say, prolonged labor, then you can eliminate antibiotics. So let's say it's a clean elective cesarean section and the baby came out and has asphyxia. However, one of the few, but you should have a very, very a low threshold of starting the child of antibiotics. Why am I saying this? It's because birth asphyxia, we are talking about it affecting every system, affects the immune system as well. So when a baby comes out and it has birth asphyxia, the immunity is very low. So you can monitor this baby closely. But if you have any reason to think that there is an infection, then you can go ahead and start your antibiotics, because birth asphyxia also affects the immune system and causes the baby to have a depressed immunity. So it cannot fight off common environmental infections. Thank you very much.
Thank you too. Michael Eku wants to know, since HIE can occur prenatally too, should doctors be encouraged to make a diagnosis of birth asphyxia in their clinical notes, since a diagnosis of birth asphyxia seems to suggest that the injury occurs always at birth, looking at the possible legal implications?
Thank you very much for your question. I think your question is more of a legal question than a medical question. Anyway, let me try my little best, because I'm not good at these law issues at all. But all that I will say is that if you are having challenges, that's why I'm saying that perinatal asphyxia, birth asphyxia, they are synonymous. They are sister terms that can be used interchangeably. So if you are comfortable with perinatal asphyxia, you can use that. You can use that, because yes, some of the events occur. If let's say the mother has preeclampsia, even before the delivery of the child, there's placenta insufficiency, and that is having a negative impact on the oxygen delivery to this baby. So even before the baby is born, there are issues. So if you are comfortable with perinatal asphyxia, you can go with that one, because birth asphyxia, as you rightly said, sometimes it always connotes that it occurred at birth, but sometimes the event, even leading to the delivery, is already predisposing the child to the asphyxia. So you can stick to perinatal asphyxia if that makes you more comfortable. Thank you.
Thank you. Can Phenobarb be administered to asphyxiated babies when seizure has not yet set in, or it can only be given when there is a seizure?
Thank you very much for your question. I believe you want to ask whether we should give prophylactic Phenobarb to birth asphyxia babies. In fact, I haven't come across any study that really supports this. We always will say that look out for the seizures. And if the seizures occur, give your anti-seizure medications. That's what we usually do. Just that usually after, let's say, a seizure has occurred and maybe has repeated itself, then you can put the baby on maintenance Phenobarb, where the baby, after, let's say, every 12 hours, the baby gets a dose of Phenobarb to prevent further seizures. But usually, the first seizure, we wait for it to happen first, and then we can give our Phenobarb. Then from there, if we are getting more persistent seizures, then we can put the baby on maintenance Phenobarb so that seizures do not recur in the child. So I will not, in fact, it's not that I will not, I haven't really seen a study that supports prophylactic Phenobarb in all babies who have birth asphyxia. I haven't come across any literature like that. If anybody has come across it, the person can share so that we pick it from there. Thank you very much.
Thank you. I think most of the questions are going to you, Dr. Free, and I can understand the passion with which you speak about birth asphyxia. So this other person wants to know, since we have limited resources for therapeutic cooling and neuroprotective care, how do we manage the sick neonates?
Okay, thank you very much. So, in our part of the world, our management is mainly supportive. Our management is mainly supportive. Having at the back of our mind that it affects almost every organ, every system in the body. So we monitor this baby. We ensure that there is optimal oxygenation of all the tissues. If there are seizures, we control the seizures. If the baby is feeding, we make sure that we start gradually, and so that the baby does not develop any necrotic enterocolitis. Gradually, we ensure that the baby is getting enough fluids, the kidneys are well perfused, all the organs in the bodies are well perfused. That's what we do. There's mainly supportive. What we do for them is mainly supportive. But if we are able to even go through this supportive care and go through very well, most of these babies will survive. In fact, the most important thing is ensuring that we resuscitate them promptly. If you're able to do prompt resuscitation, most of these babies are able to pull through. We have an experience with an asphyxiated baby. She came in flat from our labor ward, flat, nothing. There was prompt resuscitation. This baby resumed spontaneous breathing. And within a short time, this baby was able to go home. Yes, the baby had a little bit of neurological sequelae, which we were able to do physiotherapy to be able to help the baby to achieve the developmental milestones. So it's very important that we resuscitate promptly. Then from there, we continue with our supportive management. And most of our babies are able to pull through with just that. So please, we shouldn't throw our hands up in the air as if nothing can be done. The little that you do goes a long way to help these babies. So let's ensure that we resuscitate them promptly and then follow up with supportive management. And these babies will be able to make it. Thank you.
Thank you. Patricia wants to know if she can put babies with birth asphyxia on BiPAP.
Oh, yes, you can. Yes, you can. On CPAP, on BiPAP, you can. Because most of them will require respiratory support. It depends on the level of respiratory distress. Some of them, just a little bit of intranasal oxygen is okay for them. But some of them, because of severe respiratory distress, they may require more. So you can put them on CPAP, you can put them on BiPAP. The only caveat is that sometimes some of these babies with birth asphyxia also have meconium aspiration syndrome because they are born through meconium. And when it happens like that, with meconium aspiration syndrome, you should be a little cautious when you're putting them on CPAP or BiPAP. So in those babies, we will prefer non-rebreather mask, at least for the first 24 to 48 hours, after which you can now put on CPAP or BiPAP. So yes, CPAP, BiPAP, non-rebreather mask, intranasal oxygen, they all have a role to play depending on the level of respiratory distress your baby is having. Thank you.
Okay, thank you. I think the questions are many. So we'll take a question in-house as well.
Hello.
Hello.
Yes, I think someone has a question for me.
Yes,
One
Dr.
do-
Edu on the aspirin.
Yes, yes. Thank you very much. Aspirin is supposed to be given after 12 weeks. So the main benefits are when it's given between 12 and 8 weeks. The patient is supposed to take it till 36 weeks. Okay, thank you.
Thank you. So we take a question in-house and probably wrap up with that.
All right, thank you very much for your amazing presentation. My question is, after resuscitating the baby, when can we initiate feeding? Thank you.
Dr. Free, I'm sure this is for you as well.
Yes, please. Thank you very much for your question. In fact, there is no specified time that I would say that you should initiate feeding. Usually after resuscitation of these babies, we usually will wait for about 24 hours. That is when we are monitoring these babies to see how they go, they respond to our management. Then after 24 hours, if the baby is stable enough in terms of the respiration, in terms of the heart rate, the baby is stable enough, you can now start some trophic feeds where you are giving very small amount of feed. Most of the time, if it's a severely asphyxiated baby, they cannot suck. So at this point, you have to use alternate means. Either you use a tube, you do some tube feeding. Usually that's what we do anyway. We do some tube feeding. Because most of the severely asphyxiated babies, although they are a little stable, they are still in respiratory distress requiring oxygen support, and they are still in the recovery stage. So we will pass a tube and do some feeding. That is if the baby is not having any seizures. If the baby is having seizures, you wouldn't want to feed because there's a high risk of aspiration. So if there are no seizures and the baby is a little stable after your resuscitation, you can wait after 24 hours, then you can go ahead, do some trophic feeds where you give, let's say, about 2 meals of feeds in maybe a 3-hourly interval. When you give your feeds, you don't just give it and say, oh, I've given. No, you check. Is there any abdominal distension? Is there any vomiting? Is the baby able to pass stools? If these are all intact, then you are happy. You can then go ahead and continue your trophic feeds for about 24 hours. Then afterwards, if the baby is still tolerating the feeds, you can go a little bit up on the feeds. But as I said, it's a very gradual increase. You don't say that, oh, then let's say I'm going to do 20. No, you can go to, let's say, 4 meals or maybe 5 meals, and then do it in a 3-hourly interview, still monitoring the child. Is there tolerance? Is there any vomiting? Because we have said that there can be delayed gastric emptying. So you have to do that amidst close monitoring. But if the baby is having seizures, as for that, you wouldn't want to feed because it can lead to aspiration. Thank you very much.
Thank you very much to Dr. Friye. Please, for participants online and all of us, let's try to fill the evaluation form. Let's try to fill the evaluation form. And again, the questions are a lot. So I'll please plead with Dr. Edu and Dr. Friye to be answering the unanswered questions in the chat box. Sorry. So I was saying that we are pleading with all participants to fill the evaluation forms for us. Participants online in-house, please do well to fill the evaluation forms for us. And then also we plead with Dr. Edu and Dr. Efriye to answer the unanswered questions in the chat box for us. The way the questions are coming in, it means that our presenters have done a very good job and the understanding is well noted. So please, for the unanswered questions, please do well to answer in the chat box for us. Thank you very much. I have been alerted that Dr. Marion's message is ready. Unfortunately, she's been caught in another equally important meeting, so we'll be listening to her speech from Dr. Emmanuel Opon. Thank you very much. Dr. Opon, please play for us. Dr. Opon, please, if you can hear me, we can't hear from the side.
Hello, MC. Yes, so PSG administrator is playing from her end. Please give her a minute to rectify it. Thank you. Hello, Gloria.
Dr. Paul.
Yes, please check your audio options and then choose the one that you are sharing from your laptop audio.
Okay,
If
please.
it's still a challenge, I think we can move on and then find another segment to play it. This is a very important message from our guest speaker, the Family Health Director for the Ghana Health Service. So I believe it's a very wonderful message that everybody must hear.
Okay, please. I'm working on the audio.
Yes, please. We'll give you a minute. So yes, in the meantime, whilst we are waiting for this technical issue, this is Dr. Opon again, Vice President of PSG. And we want to put it out there that this fundraising efforts is to be able to identify some facilities that we know, based on all the data and evidence, that they are having peculiar challenges, and therefore their birth asphyxia cases and incidents are on the high. So the idea is that we are not going to maybe support all facilities with this equipment. We are trusting management to step in. But the idea is that at least there should be some facilities that can be supported, some places that can be supported. So we are organizing a fundraising campaign, and we are imploring everyone, philanthropists, foundations, if you know a company or an uncle somewhere, to donate so that as many facilities, as many facilities as possible can be supported. Certainly not all the facilities in Ghana, but as many as possible. So we count on all of you, your support, to be able to make this fundraising a success, not just this year, but this year and beyond. Thank you and over. I hope our administrator has been able to rectify the audio. Gloria, any success?
No, please.
Okay. MC, over to you. I think we may probably take a pause, and then maybe we'll circulate this very important message by another means. Thank you, and over for now.
Thank you very much, Dr. Vice President. Okay, so at this point, we would want to take our chairperson's closing remarks. So,
MC.
Dr. Frank Strebo.
MC, please, I am ready, please.
Okay.
MC, I am ready, please.
All right, well noted.
Okay.
Please go ahead.
Join you at the last. Thank you. Important. We need to talk about it. It's important for us to know that we can make a big difference by addressing the factors that contribute to bed asphyxia.
I think we are struggling to hear. I would recommend that we move on so that the chairperson can give us a closing remark, and then we'll find another way to get the message to our dear participants. Apologies once again. MC, over to you.
Thank you. Apologies all accepted. It is very obvious that we are dealing with the Pediatric Society of Ghana. So we have the pediatrics also registering their presence. So it's well accepted. All right. So we'll now go to our chairperson, Dr. Frank Stribble, to give us the closing remark.
Dr. Stribble wants the host to unmute him or allow him to unmute. So let's make him the co-host quickly, please. Thank you.
Thank you very much, Dr. Medopong, for finally getting me through to be unmuted. What more can I say? I think it's been a fantastic learning journey for all of us. I have learned a lot this evening, and I'm sure all of us have done the same. At least one quotation that I think everybody should take home is that there's nothing like knowing more than resuscitation is not like you can know more resuscitation. So any opportunity that we get, we should take the opportunity and learn more, because we can't learn too much. And so I think it's the take-home message for all of us. And then, of course, for Dr. Pong and his team, let's support them in the fundraising measure. I will surely be contributing, and I can promise that your mother association would also certainly contribute something. That is the Ghana Medical Association would contribute something. I've already committed them for the fundraising, so that we can equip the various hospitals with equipment, especially in line of resuscitation. So it's been a fantastic journey this evening, and I believe that we've all learned. We've had a lot of questions. Hopefully, the questions will continue to come, and our resource persons would try and answer them. And those of us who can answer some of the questions should also go ahead and support our colleagues and answer them. And so I think, MC, you worked very easy. You coordinated, and Dr. Pong came in from time to time to also make sure that at least we all make this program a success. And so thank you for the support. Hopefully we will meet again. And I'll take this opportunity to say, Ayiko, yes, thank you so much.
Thank you, Dr. Chair.
Over. Host, the MC, over.
Thank you, Dr. Chair. I'd like to personally, on behalf of the PSG, thank you for your promise of a support to the society. Thank you very much. We'll be reminding you from time to time as well. Thank you. All right, so we want to go to Dr. Opon for your announcement. Dr. Opon, over to you, please.
Oh, thank you so much. Wow, it's been a very enlightening program. And I want us to take note of this announcement. September is Birth Asphyxia Awareness Month. It's also Childhood Cancer Awareness Month. And we want all of us to take part in all the advocacy activities happening across the whole country. Next week, Thursday, on the 12th of September, we'll have a national launch of the Childhood Cancer Awareness Month. This will be Thursday next week. And then the following day, Friday 13th, we will have the World Sepsis Day celebration. So you can see that September has a lot of good things for all of us to be able to champion the welfare of children. As we're going through, realize that there are a number of questions that are on people's minds. Take note that on the 27th of September, there will be a national public forum on birth asphyxia, where we'll try and engage as many members of the public as possible. They'll all be on the call, but we are inviting everyone else. So reach out to your church members, reach out to your social network friends and family so that everyone can join. And I believe that it will be a very informative and very educational segment. So September is packed for us. Let's get involved with facility, whichever facility that you are at, get involved. Find something to do so that you advocate for the well-being of children as we've always done over the years. And thank you, MC and Brong Ahafo region for having such a wonderful, wonderful hosting segment for birth asphyxia awareness. Over for now. All our greetings to everyone from the National Executive Committee of PSG. Thank you and over.
Thank you, Dr. Okon. Thank you too for trusting the BA division to host this all-important lunch. We'd like to take a vote of thanks from Dr. Asibe. Dr. Asibe, vote of thanks. Over to you, please.
Hello, good evening. Sorry, I was unmuted. Thank you so much. Thank you. We want to say a big thank you to the PSG National Executive for trusting us with this program. We are grateful to our chairperson, our very own Dr. Med Frank Strebo. We are grateful to our guest of honor, even though she couldn't make it, she sent us a solidarity message. We are very grateful. So God and all the other message team members that sent us messages. We are grateful to you, Sunyani Teaching Hospital, Sunyani Municipal. Thank you for pulling this together. Dr. Siama, Dr. Jennifer, we are grateful. All the executives of Pediatric Society. We want to say we are grateful for this opportunity. Thank you all for coming. And we want to continue to say that, please, this month, everybody should be able to do at least one HBB training and then in Pascals. We are grateful. So on behalf of the planning committee, the BAR planning committee team, we officially launched the Birth Asphyxia Awareness Month, September 2024. Thank you very much. Over to you.
Thank you so very much. Thank you all for your patience and for your participation. I have been your MC, Ajo Enchidia. We'll take our closing prayer from Dr. Bright Siama.
Thank you, Madam MC. So we are praying. Heavenly Father, we thank you for today. We thank you for blessing us with today. We thank you for the knowledge that we have acquired today. Father, we are praying that we're able to put what we have learned today into practice to reduce the incidence of birth asphyxia in our facilities and reduce the mortality in general. Thank you for the successful program for today. Amen. Thank you.
Thank you so much.